Welcome to this explainer. Today we're taking a deep academic dive into the clinical pathology of viral warts. This is a truly fascinating intersection of virology and dermatology. We aren't just looking at surface-level skin conditions today, we are examining the complex, real-time biological interactions between human tissue and a highly adaptive virus.
Here is the roadmap for our clinical framework today. We're going to cover 1. The etiology of viral warts. 2. Clinical typology and presentation. 3. Prognosis and clinical course. 4. Identifying differential diagnoses. And finally, 5. Therapeutic and management strategies. Let's jump right in.
Starting off with Section 1, the etiology, or the root causes of viral warts.
To set our academic baseline, viral warts are incredibly common growths, especially something we observe a lot in childhood. But here is the kicker. They are triggered exclusively by the human papillomavirus, or HPV. They pop up on both keratinized skin and delicate mucous membranes. It's absolutely crucial to remember that this is a viral infection we're dealing with, not just some random localized cellular mutation. Grasping that etiology is the foundational step in mastering this dermatological pathology.
Now you might be wondering, are all warts basically the same? No way! Specific HPV strains literally map out to distinct clinical manifestations. For instance, the common wart, that's primarily driven by HPV types 1, 2, and 4. In stark contrast, plain warts are tied to HPV 3, and genital warts are overwhelmingly linked to type 6, 11, 16, and 18. This genetic specificity is just mind-blowing because the virus's specific DNA directly dictates the morphological presentation you'll see on the patient's skin.
So, how does this actually spread? Well, transmission happens when viral particles, specifically those hiding out in desquamated or shed skin scales, find their way into microscopic tears in the skin or mucous membranes. The virus literally exploits a tiny physical vulnerability in the skin's barrier. Furthermore, this pathogenesis is significantly exacerbated when a patient's systemic immunity is suppressed, which basically gives the virus a free pass to activate and proliferate completely unchecked.
Moving on to Section 2, let's break down the clinical typology and morphological profiles.
Notice how the anatomical location completely changes the physical presentation. Common warts usually start out as smooth, skin-colored papules, but over time they develop this classic hyperkeratotic, meaning thickened, surface as the lesion grows. Pain is super rare here. But then look at plantar warts on the weight-bearing surfaces of the feet. Because they are driven inward by the pressure of walking, they present as rough, slightly raised lesions encased in a tough, horny collar. And man, they can be intensely painful for the patient.
We also observe mosaic warts, which are clinically fascinating. These present as tightly packed, rough plaques. Picture multiple small warts merging together into one big puzzle, usually found on the soles, palms, and around fingernails. They're generally painless. This contrasts sharply with plain warts, which are these multiple, smooth, flat-topped papules. You'll frequently spot these on the face or the backs of the hands. Uniquely, plain warts are the ones that frequently just resolve spontaneously without any clinical intervention at all.
From an epidemiological and pathological standpoint, anogenital warts, or condyloma acuminata, represent a totally distinct category. These are papillomatous, cauliflower-like lesions that have a moist, macerated, and highly vascular surface. They can even coalesce into large obstructing masses. In adults, they're primarily spread via autoinoculation, but here is a massive clinical imperative to remember. If you see these in pediatric cases, you absolutely must maintain a high index of suspicion for sexual abuse.
To round out our typologies, we find filiform warts, characterized by their long, stalk-like morphology, usually localized right on the face. Then we have periungual warts. These cause thickened, fissured skin directly around the nail plate. They are particularly troublesome because they can painfully compromise the nail bed, cause paronychia, which is inflammation of the nail fold, lead to cuticle loss, and honestly, they can easily mimic a fungal infection, like onychomycosis, if you aren't looking closely.
All right, on to Section 3, prognosis and the natural clinical course of the disease.
So what happens if we do nothing? Well, the host immune response plays a massive, decisive role here. As the data shows, 30% of warts spontaneously resolve within 6 months, and an additional 35% clear up by the 2-year mark. That means a total of 65% just resolve on their own within 2 years in healthy individuals. Clinically, you'll know this immunological victory is happening when the wart suddenly turns black. Pathologically, that indicates capillary thrombosis. The immune system is literally cutting off the blood supply to the wart.
However, the story completely deviates for our immunocompromised populations. For them, the timeline and the severity are totally altered. Take kidney transplant recipients, for example. They often develop widespread warts years after their procedures simply due to their immunosuppressive therapy. And much more concerningly, these populations face severe dermatological complications, including epidermodysplasia verruciformis or the lesions transforming into outright malignancies.
Let's pivot to Section 4, Identifying Differential Diagnoses. In dermatology, diagnostic precision is absolutely paramount.
Notice the vital diagnostic distinction here. Differentiating a plantar wart from a simple mechanical plantar corn relies entirely on vascular observation. It's a classic board-style question. If you pare down the hyperkeratotic tissue of a plantar wart, you're going to observe pinpoint bleeding capillary loops. A plantar corn, on the other hand, will reveal a hard central keratotic core with absolutely zero capillary bleeding. It's a simple, elegant physical exam technique that confirms the diagnosis right then and there.
Clinicians also must systematically rule out a bunch of other cutaneous conditions. You've got viral mimics like molluscum contagiosum, inflammatory conditions like granuloma annulare, and even condyloma lata from secondary syphilis. But critically, the absolute highest stakes distinction a practitioner must make is rigorously differentiating benign viral warts from aggressive epithelial cancers. You absolutely cannot afford to misdiagnose an amelanotic melanoma or a squamous cell carcinoma as a simple wart.
Finally, we arrive at Section 5, synthesizing our findings into therapeutic and management strategies. Clinical management utilizes a fantastic escalating ladder of interventions. We start with mere observation, which honestly is often the best move for plain warts given how frequently they resolve on their own. Step 2 brings in the topicals. Think 12 to 20% salicylic acid for at-home treatment, or clinical cryotherapy using liquid nitrogen. Advanced interventions, like electrosurgery, laser treatment, or straight-up surgical excision are strictly reserved for those highly resistant or deeply embedded lesions, like stubborn mosaic or periungual warts.
Now, if we are dealing with anogenital warts, the treatment paradigm shifts dramatically. While we do use topical creams like podophyllitoxin or amikimod for the lesions themselves, the overarching management requires highly targeted preventative care. Because of the viral etiology, clinical protocols mandate regular cervical cytology, pap smears, for female patients, and strongly advocate for prophylactic HPV vaccination to prevent any subsequent infections.
The reason for this aggressive preventative stance is captured perfectly in this critical finding. HPV types 16 and 18 are explicitly linked to the development of cervical carcinoma. This single epidemiological fact underscores exactly why precise dermatological identification of viral warts isn't just a cosmetic concern, it is a vital, life-saving step in preventing severe, systemic malignant complications. Which brings us to an ultimate provocative question right at the intersection of public health and microscopic pathology. If 65% of wart cases resolve completely naturally through our own immune response, yet specific, highly adapted strains carry such potent oncogenic risks, how will the widespread global adoption of preventative vaccines alter the evolutionary landscape of the human papillomavirus in the decades to come? It's a fascinating scientific frontier to consider. Thank you so much for joining me on this explainer.